Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI Vidyapeeth Province University, Jaipur. In today's lecture, we are going to discuss about angioedema. You can see the condition of angioedema in the right picture. In the left, there is a young man with normal appearance, and in the right picture, the same man with angioedema during an acute attack. So angioedema is the episodic, localized, non-pitting swelling of the submucous or subcutaneous tissue. This most frequently affects the face, the extremities, and the genitalia. The involvement of the larynx or the tongue may cause life-threatening respiratory tract obstruction, and edema of the intestine may cause abdominal pain and distension. The pathogenesis. In most of the cases, the underlying mechanism is degranulation of the mast cells. However, angioedema may occasionally be mediated by increased local bradykinin concentration. It may be a manifestation of allergy or no allergic degranulations of the mast cells in response to drugs and toxins. This causes the mast cell degranulation with release of histamine and other vasoactive mediators. The hereditary angioedema, the cause is C1 inhibitor deficiency, which causes increased local release of bradykinin. Angiotensin converting enzyme ACE inhibitor induced angioedema also occurs as a result of increased bradykinin levels due to the inhibition of its breakdown. The clinical features. Angioedema is characterized by soft tissue swelling that most frequently affects the face. It can also affect the extremities and the genitalia. The involvement of the larynx or tongue may cause life-threatening respiratory tract obstruction, and edema of the intestinal mucosa may cause abdominal pain and distension. The investigations. The differentiating the mechanism of angioedema is important in determining the most appropriate treatment. A clinical history of allergy or drug exposure can give clues to the underlying diagnosis. If no obvious trigger can be identified, measurement of complement C4 is useful in differentiating hereditary and acquired angioedema from the other causes. If C4 levels are low, further investigations initiated to look for the evidence of C1 inhibitor. Now, the management of angioedema. The management depends on the underlying cause. It is associated with allergen exposure, generally responds to antihistamines and glucocorticoids. Following acute manifestations, management of angioedema, secondary to drug therapy, drug withdrawal should prevent further attacks. ACE inhibitor-induced angioedema can continue for a limited period of post-drug withdrawal. Now, there are different types of angioedema. We have 4 predominant types. Number 1 is allergic reaction to a specific trigger. The second is idiopathic angioedema. Third is hereditary angioedema. And the fourth one is ACE inhibitor associated angioedema. We are going to discuss them one by one through this table itself. So let's start with the first one, that is allergic reaction to specific trigger. It is the pathogenesis is IgE mediated degradation of mast cells, and the key mediator is histamine in this case. It is more common in prevalence, and the clinical features usually are associated with urticaria. There is history of other allergies that are most common, and it occurs following the exposure to specific allergens like in food, animal, dander, or insect venom. The investigation in this case is specific IgE test or skin prick test, and the treatment of allergic reaction to specific trigger consists of allergen avoidance and antihistamines. The associated drug reactions are specific drug allergies. So this was all about allergic reaction to specific trigger. Now we come to the second one, that is idiopathic angioedema. The pathogenesis, it is non-IgE mediated degranulation of the mast cells. Histamine is again the key mediator in this type as well, and the prevalence is common. The clinical features, it is usually associated with urticaria as similar to that of allergic reaction to specific triggers, and it may be triggered by physical stimuli such as heat, pressure, or exercise. There is presence of dermatographism, and occasionally it is associated with underlying infections or thyroid disease. In investigation, again, we have to check for specific IgE test and skin prick test that are often negative, and hypothyroidism has to be excluded. The treatment consists of antihistamines, which are the mainstay of the treatment, and prophylaxis. And the associated drug reaction consists of NSAIDs, opioids, and radiocontrast media. The third one, we come to the hereditary angioedema, and the pathogenesis consists of C1 inhibitor deficiency with resulting in increased local bradykinin concentration. The key mediator here in this case is bradykinin. The prevalence is a rare autosomal disorder. The clinical features, it is not associated with urticaria or other features of allergy, does not cause anaphylaxis. It may cause life-threatening respiratory tract obstruction and can cause severe abdominal pain. The investigation consists of complement C4 invariably low in acute stages and C1 inhibitor levels. The treatment consists of unresponsive to antihistamines, and anabolic steroids are given, and C1 inhibitor concentrates or icatibant for acute attacks. Now we come to the fourth one, that is ACE inhibitor associated angioedema. The pathogenesis consists of inhibition of the breakdown of bradykinin, and the key mediator is bradykinin. So we can see in first two cases we have histamine as the key mediator, and in the last two we have bradykinin as the key mediator. The prevalence of ACE inhibitor associated angioedema is 0.1 to 0.2% of the patient treated with ACE inhibitors. The clinical features, it is not associated with urticaria and does not cause anaphylaxis. It usually affects the head and neck and may cause life-threatening respiratory tract obstruction. It can occur years after the starting of treatment. There is no specific investigation in such case, and the treatment consists of ACE inhibitors, which has to be discontinued, and ARBs should be avoided if possible unless there is strong indication. The drug-associated reactions consist of ACE inhibitors and ARBs. So this was all about angioedema. In the next topic, this completes with the syllabus of the third year. We have already covered all the topics, and the topics that I have already covered in the classroom and not discussed during this lockdown period, I have made the videos of those lectures as well, and I have uploaded those videos on the portal. So you can see all the videos for the session that has been covered in the classroom, as well as the sessions that are prepared during the lockdown. So you can find all the videos, all the study material, and everything is available to you. So this session was powered by digital version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. I have also uploaded practical sessions in the portal. You can look for those practical sessions and you can learn from them. If you have any problem, you can ask me anytime, and your problem will be sorted out. So this was all for today. Thank you very much. Have a good day.